Welcome to the deep dive. We're jumping into a stack of your sources today. Notes, articles, research all about chronic venous disease and, well, it's pretty serious consequence, venous ulcers.
That's right. Think of this as um, getting under the hood of the plumbing and your legs, the veins specifically, and figuring out what happens when that system, starts to fail. We're digging into the key insights from the materials you've gathered.
Yeah, our mission here is to really unpack everything you've provided. We want to follow the journey of this disease from the maybe subtle signs right through to the major issues, how it's spotted, and the different ways it's managed.
Exactly, getting a solid handle on it.
So we'll cover the whole spectrum, right? The underlying causes, diagnosis, treatment, highlighting the really crucial bits from your sources.
That's the plan. From basic function to complex problems like ulcers.
Okay, let's get into it then. Your sources kick off by defining chronic venous disease, CVD, and chronic venous insufficiency, CVI. How do they actually distinguish those two?
Well, the sources frame CVD as like a big umbrella term. It covers everything from tiny spider veins, telangiectasias, technically right up to the really severe end, which is venous ulcers.
Okay.
CVI, on the other hand, is specifically defined as what happens because of chronic venous hypertension.
Chronic venous hypertension. So basically just persistently high pressure inside those leg veins.
Exactly that. And that high pressure, according to your sources, usually boils down to one of three things, or maybe a mix. You've got an obstruction blocking flow, the valves inside the veins aren't doing their job, or that natural muscle pump system in the legs is failing.
Right, the pump. We'll get to that. And this isn't exactly a niche condition, is it? Your materials really stress how common it is.
Oh, incredibly common. We're talking millions of people affected. Something like 2.5 million in the U.S. have CVD, and maybe 20% of them end up developing ulcers, which is significant. And just varicose veins, the more visible kind they affect, up to 40% of adults. It's especially common in certain groups, like people carrying extra weight or women who've had several pregnancies.
40%. That's huge. A huge number of people potentially dealing with some level of this. So, okay, why? Why does this happen? What are the big risk factors your sources highlight?
Yeah, the list is quite revealing, actually. It points to the stress on our legs. Getting older is one factor. Family history definitely plays a role, suggesting a genetic component.
Mm-hmm.
Being female, particularly with pregnancies, bumps up the risk. Then there are jobs that involve standing all day. That's a big one. It reminds me of that case study you sent, JD, the construction worker.
Right, the construction worker, yeah.
His symptoms getting worse through the day, classic standing occupation issue. Obesity is high on the list, too. Smoking, a history of blood clots, DVT, or vein inflammation, phlebitis.
Okay.
Also things like oral contraceptives, hormone replacement therapy, not being active enough, physical inactivity, and leg injuries.
So it's a mix, isn't it? Some things you can't control, like genetics or age, but others are more lifestyle related. Your sources also mention primary versus secondary.
Yes, that's a key distinction for understanding the root cause. Primary CVD is basically when the vein walls or the valves just weaken over time, degenerate, without one clear trigger.
Kind of wear and tear?
Sort of, yeah. Whereas secondary CVD usually follows something specific, most commonly a deep vein thrombosis, a DVT. The clot damages the vein, damages the valves, and sets the stage for long-term problems.
That makes sense. Okay, to really get why those risk factors matter, we probably need a quick refresher on how the system is supposed to work. Can you walk us through the leg vein anatomy?
Sure. Your sources lay out three main networks of veins in the leg. You've got the superficial system, which is just under the skin, that includes the big ones you might have heard of, the great and small saphenous veins.
Right.
Then, deeper down, inside the muscle compartments, is the deep system. This is the real workhorse, handling about 90% of the blood heading back to the heart.
90%, wow.
Yeah, it's the main highway. And then you have perforating veins. These are like connector roads, allowing blood to move from the superficial system into the deep system. Crucial connections.
And it's not just passive flow, right? There's a mechanism pushing blood uphill against gravity.
Absolutely critical. It's the calf muscle pump. When you walk, flex your foot, tense your calf. Those muscles squeeze the deep veins.
Okay.
That squeezing action literally propels blood upwards towards the heart.
Yeah.
It's really effective when you're moving. Your sources point out the calf pump ejects a lot of blood, maybe 65% of the volume with each squeeze, compared to the thigh pump, which is much less, like 15%.
Okay, so muscle squeezing pushes blood up. But what if you're just, say, standing still at that job?
And that's a really key point from your material. The calf pump doesn't work effectively when you're standing stock still.
Oh,
That lack of pumping action is a major reason why those standing occupations are such a big risk factor. You lose that essential boost against gravity.
fascinating. So just standing there, gravity wins more easily. And you mentioned valves earlier.
Exactly. The valves are crucial too. Think of them as tiny one-way gates inside the veins, usually with two little flaps or cusps. Their entire job is to make sure blood only flows one way.
Upwards.
Upwards towards the heart, yeah. And also from the superficial veins through those perforators into the deep system, they snap shut to stop blood falling back down.
Okay, so pump pushes up, valves stop backflow. That's the ideal. What goes wrong? Where does the breakdown happen?
This is where we get into incompetent veins and reflux. Incompetent just means the valves aren't closing tightly anymore. Maybe they've been damaged, like after a DVT, or maybe they've just become weak or floppy over time.
And reflux means?
Backward flow. Simple as that. When those valve gates don't seal properly, blood leaks backward, going the wrong way. This is a major problem, especially in the deep veins and those perforating veins.
How so?
Normally, when the calf muscle relaxes after squeezing, the pressure inside the deep veins drops. This helps pull blood in from the superficial system. But if the deep vein valves are leaky, that backward flow stops the pressure from dropping like it should. And worse, if the perforator vein valves fail, when the calf muscle squeezes, it can actually force high-pressure blood out from the deep system into the lower-pressure superficial system, the opposite of what should happen.
Whoa, so the pump starts working against itself almost, pushing blood the wrong way.
Essentially, yes. That backward flow, especially when you're walking and the pump is active, creates what's called ambulatory venous hypertension, high pressure when you move. And it's that sustained high pressure, particularly down around the ankle, that causes the symptoms, the skin damage, and eventually, potentially, ulcers.
That really connects the dots between the anatomy and the problems people experience. So what does this actually feel like for someone? How is it assessed?
Well, people often start by noticing subjective things, how their legs feel. Your sources list common symptoms like aching, a feeling of heaviness, burning, itching, fatigue in the legs, stinging, throbbing, sometimes even a type of leg cramp called venous claudication, which comes on with activity but usually eases pretty quickly when you stop.
Unlike arterial claudication.
Right? Different pattern. And typically, these venous symptoms get worse as the day goes on. Worse after standing or sitting for a long time, and feel better when you put your feet up. That JD case you mentioned, the construction worker.
Yeah.
Perfect example. Symptoms tied to his standing job, worse by evening. Classic pattern.
And what would a doctor actually see when they examine the legs?
They're looking for the objective signs. Swelling or edema is really common. Usually starts around the ankle, might creep up the calf. At first, it might be pitting edema. You press it, leaves a dent. But over time, as the tissues change from that chronic pressure, the edema can become firm, non-pitting, sometimes described as brawny or even woody edema.
Right.
And you often see that characteristic brownish staining on the skin, especially around the inner ankle, the gaiter area.
Yeah.
That's hemosiderin staining from red blood cells leaking out over time. You might also see eczema-like changes, dermatitis, itchy, scaly skin. A more advanced sign is lycodermal sclerosis. That's where the skin and the tissue underneath become really hard and tight, sometimes giving the lower leg that inverted champagne bottle look.
Ah, I've heard that description.
Yeah. And then there's atrophy blanche. These are little white, maybe star-shaped patches of very fragile, thin skin. Those are warning signs, areas really prone to breaking down into ulcers. It's also important to check pulses, make sure there isn't also an arterial problem, though bad swelling can make pulses hard to feel sometimes. And measuring the leg circumference helps track that swelling.
It sounds like a definite progression of visible changes. Your sources mention classification systems too. CEEA.
Yeah, CEAP is the standard way clinicians classify and communicate about the disease. It stands for clinical, etiologic, anatomic, and pathophysiologic. The C part, the clinical score, goes from C0, no signs, all the way up to C6, which is an active ulcer. There's also another one, the Venous Clinical Severity Score, or VCCS. It's designed to be a bit more sensitive for tracking changes over time, looking at things like pain, the amount of edema, specific skin changes, ulcer status, and whether compression is being used.
Got it. So a doctor sees these signs, hears these symptoms. How do they confirm what's really going on inside the veins? What are the key diagnostic tests?
The absolute go-to test, the main one mentioned in your sources, is duplex ultrasonography.
Ultrasound.
Yeah. It's non-invasive, gives a ton of information. It combines regular ultrasound imaging, so you can actually see the veins, with Doppler ultrasound, which measures blood flow.
How does that help?
It's brilliant, really. It can show if there's a blockage, like is the vein compressible? Is flow totally absent? But crucially, it's the best way to detect leaky valves, that valvular insufficiency or reflux we talked about. The technician can actually watch the screen and see if blood flows backward. Usually when a patient does something like bear down, the Valsalva maneuver, or when they squeeze the leg below the probe, they measure how long that backward flow lasts. Generally, more than a second is considered significant reflux.
So it clearly shows if the pipe is blocked or if the gates are leaky.
Exactly. It gets right to the core problem, obstruction or reflux. Your sources mention a few other tests too, like MRV or CTV, that's MRI, or CT scans focused on veins. They can be useful for looking higher up in the pelvis or abdomen, areas ultrasound struggles with.
Right.
And there are some physiological tests like air plethysmography, APG, which measures volume changes to assess overall pump function and reflux, and photoplethysmography, TCG, a simpler light-based test. But really, duplex ultrasound is the main diagnostic tool.
Makes sense. So once the problem's identified, how do you manage this, especially before it gets to the ulcer stage?
Well, the foundation really is supportive care. Simple things that can make a big difference. Leg elevation is huge. Higher than the hips when you're sitting, ideally higher than your heart when you're lying down. That uses gravity to help drain the legs, reduce that pressure and swelling.
Okay.
Doing calf exercises, just simple foot flexion and extension, ankle pumps that helps activate that calf muscle pump we discussed. And skincare is really important. Using good moisturizers every day keeps the skin supple. Gentle exfoliation if it gets dry and thick. And if there's dermatitis, that itchy rash, using topical steroids can calm it down.
And then the big one, compression. It comes up again and again in your material.
It absolutely does. It's the cornerstone of managing venous disease with or without ulcers. Compression basically works by giving external support. It counteracts that internal hydrostatic pressure, helps squeeze blood back up the veins, and reduces the swelling.
Is it just tight socks?
Well, proper medical compression is graduated. That means it's tightest at the ankle and gradually gets less tight as it goes up the leg. This helps push fluid upwards. Prescription stockings need to be measured properly, ideally when swelling is minimal, to get the right fit.
What kind of pressure?
Your sources suggest typically around 20-30 millimeters of mercury pressure for, say, primary varicose veins. It might need to be higher, up to 60 even, for more severe CVI or after an ulcer.
Do they need to go all the way up the leg?
Often, knee-high is enough because a lot of the problematic pressure builds up below the knee. The key things are proper fit and wearing them consistently. And your sources stress, they wear out, they lose their elasticity. So they need replacing, usually every 6 months or so.
Right. That's important. Compliance could be an issue too, I imagine.
Definitely. Education on why it's important and how to put them on correctly is vital.
What about medications? Are there pills that can fix the veins?
Your sources mention a few drug classes that have been looked at, especially in Europe. Things like flavotropic agents, horse chestnut seed extract is one example often mentioned. Also, hemorrhagic agents like pentoxifylline, which affects blood flow properties. Even antiplatelet agents like aspirin. These are mostly studied for helping with symptoms like pain and swelling, or potentially boosting ulcer healing rates by reducing inflammation or improving microcirculation.
But they don't fix the underlying valve problem.
No, they don't correct the anatomical issue, the leaky valves, or the failed pump mechanism itself. They're more for symptom management or supporting healing.
Okay. So if those conservative steps aren't enough, or if there's a really significant reflux problem and the superficial veins causing trouble, invasive treatments come into play. What are the common ones?
Yeah, the goal here is usually to get rid of the source of that reflux, typically in those main superficial veins. Sclerotherapy is one method, often used for smaller veins, spider veins, small varicose veins.
What does that involve?
Injecting a chemical solution directly into the vein. It irritates the vein lining, causes it to scar up, thrombose, and eventually just close off and get absorbed by the body. Compression afterwards is key.
And for the bigger veins, like the saphenous veins you mentioned?
For those, radiofrequency ablation, RFA, and endovenous laser ablation, EVLA or EVLT, are very common now. They're minimally invasive, often done right in the doctor's office.
How do they work?
A thin catheter or laser fiber is threaded up inside the problematic vein. Then, either radiofrequency energy or laser energy delivers heat directly to the vein wall. This heat essentially damages the vein lining, causing the vein to shrink, collapse, and seal itself shut from the inside.
Closing it off that way. Are there checks needed beforehand? Risks?
Absolutely. First, you must make sure the patient has good arterial circulation. That's where checking the ankle brachial index, the ABI, comes in again. We'll talk more about that with ulcers, but it's critical. Active infection is also a no-go. As for side effects, some temporary numbness or tingling, bruising, or pain along the treated vein are fairly common. More serious things like blood clots, DVT, or skin burns are much less common but possible. Standard aftercare involves wearing compression, walking regularly, avoiding prolonged standing or sitting, and elevating the leg.
Okay. And is there still a place for the more traditional surgery?
Yes, sometimes. High ligation and stripping of the great saphenous vein is the classic surgical procedure. It's done in an operating room, usually under anesthesia. The surgeon makes an incision, typically in the groin, ties off the connection between the saphenous vein and the deep femoral vein, and then often physically removes or strips the vein down the leg.
Sounds more involved.
It is more invasive than ablation, definitely. Carries the usual surgical risks, infection, bleeding, nerve injury. And recovery usually involves wearing compression for quite a while afterwards, maybe even lifelong if there's underlying deep vein disease too.
Okay, that gives a good overview of managing CVD before ulcers develop. Now let's shift focus to that really challenging stage, the venous ulcers themselves.
Right. Venous ulcers are the end stage, really. C6 in that CEAP classification we talked about. They happen because that chronic venous hypertension has gone on so long, it's actually caused the skin and underlying tissue to break down.
What do they typically look like? Location, appearance?
The classic spot, as mentioned in your sources, is around the inner ankle bone, the medial malleolus, that whole lower leg area, sometimes called the gator region. The ulcers themselves are often shallow, might have quite a bit of drainage or exudate. The base might look yellowish because of fibrin or slough, which is dead tissue. But ideally, you also want to see some healthy, red, bumpy granulation tissue, which means it's trying to heal. The edges are usually irregular, not nice and neat. And they can be painful, especially when the leg is hanging down.
And looking at the skein around the ulcer, the peri-wound, that's important too, right?
Absolutely crucial. You nearly always see signs of the underlying venous disease there. That brown hemosiderin staining is usually obvious. Swelling, edema is typically present, maybe that firm brawny type if it's long-standing.
Yeah.
You'll often see lipodermatosclerosis, that hardened, tight skin, maybe contributing to that inverted bottle shape. And look out for those fragile white patches, atrophy blanche, because those are high-risk spots for breakdown. Dermatitis, the itchy, flaky skin, is common too, and you might see visible varicose veins nearby.
Okay.
Pulses should still generally be palpable unless the patient also has arterial disease, which complicates things.
Yeah.
That Mrs. B case study you shared,
Yes.
it really highlighted that progression, long history of swelling, discoloration, then the skin hardened, and finally just a small bump led to the ulcer because the tissue was already so compromised.
Yeah, it shows how vulnerable that skin becomes. Now, what about specific tests when an ulcer is actually present?
The single most important test, the one your sources emphasize absolutely must be done before starting compression therapy for an ulcer, is the ankle brachial index, the ABI.
We touched on this for ablation, but why is it so non-negotiable here?
Because compression is the cornerstone treatment for venous ulcers, but it can be dangerous if the patient also has significant peripheral arterial disease.
Yeah.
Poor blood flow to the foot. The ABI measures that arterial flow.
How does it guide treatment?
If the ABI is good, say above 0.8, then therapeutic compression is generally safe and indicated. If it's in a borderline range, maybe 0.5 to 0.8, you have to be cautious, use lower levels of compression, monitor closely. But if the ABI is low, less than 0.5, indicating severe arterial insufficiency, then standard static compression is usually contraindicated. It could cut off what little blood flow is getting there.
That's a critical safety check. Makes total sense. Check the inflow before you squeeze the outflow pipes harder.
Precisely. Venous ultrasound is usually done too. First, to rule out an acute DVT, sometimes an ulcer can pop up around the same time as a clot. And second, to map out the veins, often done with the patient standing, to see if there's underlying superficial reflux that could be contributing to the ulcer. Fixing that reflux with ablation or surgery might be needed to help the ulcer heal and, importantly, stay healed. Occasionally, a venogram might be considered if they suspect a blockage higher up, like in the iliac veins in the pelvis. Sometimes stenting that blockage can significantly help healing.
Right. So, okay, we've checked the ABI, we know the venous anatomy. How do you actually treat the ulcer itself? What are the main goals?
Again, the absolute core principle running through your sources is reduce or eliminate the underlying cause, which means tackling that venous hypertension. And how do you do that?
Compression.
Compression, compression, compression. It really is foundational. It helps push the fluid back, reduces the swelling, counteracts that damaging pressure, and basically creates a much better environment for healing to happen at the ulcer site.
What kinds of compression are used for ulcers?
Your sources describe a few types. There's static compression, which provides continuous pressure. Multi-layer compression bandages are common, applied by a clinician, changed maybe once or twice a week. Compression stockings can be used too, when swelling is down, but need careful measurement.
Okay.
Then there's inelastic compression, things like the Boot, which is like a medicated gauze wrap that hardens, or newer orthotic wrap devices with straps. These work best when the patient is actually walking, because they provide firm resistance for the calf muscle to pump against.
Interesting.
And there's dynamic compression using intermittent pneumatic compression, IPC pumps. These have inflatable sleeves that squeeze the legs sequentially, often used for an hour or two, maybe once or twice a day, can sometimes be used even with slightly lower ABIs.
And elevation is still important.
Still absolutely vital. Getting the legs up above the heart level whenever possible helps drain that excess fluid and reduce pressure.
Okay, compression and elevation tackle the cause. What about treating the actual hole in the leg, the wound care?
Yeah, the wound bed itself needs careful attention. First step is often debridement, removing any dead, non-viable tissue, that yellow slough or black eschar. Healthy tissue can't grow over dead tissue.
How is that done?
Several ways. Autolytic debridement uses special dressings, like hydrogels or hydrocolloids, that keep the wound moist and allow the body's own enzymes to break down the dead stuff. Enzymatic debridement uses prescribed ointments containing enzymes, like collagenase, and sharp debridement is when a clinician physically removes the dead tissue with instruments.
Okay. What about infection? Are these ulcers often infected?
Well, all chronic wounds will have bacteria living on them. They're contaminated. But you need to distinguish contamination from actual clinical infection.
What are the signs of infection?
Your sources list things like increasing pain at the ulcer site, spreading redness around the wound, maybe warmth, an increase in the amount or change in the character of the drainage, maybe a bad odor, or if the wound just stops healing or starts getting bigger. If infection is suspected, a wound culture is important to see exactly what bacteria are causing the problem and what antibiotics they're sensitive to.
So how are infections treated? Topical creams? Pills?
Gentle cleansing is important, using non-toxic solutions. Sometimes topical antiseptics might be used for short periods if the bacterial load is very high. Topical antibiotics, creams, or ointments are used specifically to treat a diagnosed superficial infection, not just routinely put on every wound.
Right.
Silver dressings are mentioned quite a bit in your sources. Silver has broad antimicrobial properties and can help manage bacteria and odor. They come in various forms, foams, gels, alginates. If there's a deeper or spreading infection, systemic antibiotics, pills, or sometimes IV are necessary.
And the dressing itself, just to cover the wound, what's the goal there?
The main goal is to create the optimal environment for healing. That means choosing a dressing that can handle the amount of drainage, absorb excess exudate without drying the wound out. So for a heavily draining wound, you'd use something very absorbent, like a foam dressing or a calcium alginate.
Okay.
If the wound is dry, you might use a hydrogel to add moisture. The dressing should also keep the wound surface moist, provide some thermal insulation, and protect it from further injury or contamination. And protecting the skin around the wound is vital too, using barrier creams to prevent maceration from drainage, treating any dermatitis.
It sounds like a lot to balance. What happens if an ulcer just seems stuck, it's not healing, despite good care?
Yeah, that's often called a stalled wound.
Yeah.
Your sources suggest if there's no significant progress after about 4 weeks of appropriate treatment, you really need to step back and reevaluate.
What do you look for?
Definitely consider getting another culture. Could there be a hidden low-grade infection? And very importantly, consider a biopsy of the ulcer edge. You need to rule out less common causes that can masquerade as venous ulcers, like skin cancer or vasculitis.
Right.
If those are ruled out and the compression and basic wound care are optimized, that's when you might consider more advanced therapies. Your sources list things like collagen dressings, negative pressure wound therapy, NPWT or wound vacs, bioengineered skin substitutes, specialized ultrasound mist therapy, maybe even referral for surgical skin grafting.
Wow, quite a range of options. And keeping track of all this must be crucial.
Absolutely. Good documentation is essential, recording the wound characteristics, the peri-wound skin condition, the ABI results, the exact treatments being used, how the wound is responding week to week, and what education you've given the patient. It's all vital for managing these complex long-term wounds.
Which leads us perfectly into maybe the toughest part, preventing these ulcers from coming back after they finally heal. Your sources really emphasize long-term maintenance, don't they?
They do, because the recurrence rate for venous ulcers can be depressingly high if the underlying venous hypertension isn't continuously managed. The absolute bedrock of prevention is lifelong use of compression stockings for anyone who's had an ulcer or has significant venous disease.
Lifelong.
Lifelong. And remembering to replace them regularly every 4-6 months as they lose their stretch.
And the other lifestyle factors we discussed earlier, still important.
Absolutely critical. Meticulous skin care every day,
Yeah.
gentle cleansing, moisturizing, keeps the skin barrier healthy and more resilient. Regular exercise, especially walking or aquatic therapy, keeps that calf pump working. Managing weight is huge, since obesity is a major contributor.
Right.
And sometimes, even after an ulcer has healed, going back and treating underlying severe superficial venous reflux with ablation or surgery might be considered to reduce the risk of it coming back.
This has been a really thorough deep dive. We've gone from the basic plumbing of leg veins, understanding how valves and the calf pump are supposed to work.
To what happens when they fail, leading to that chronic high-pressure venous hypertension.
Yeah, and how that manifests in symptoms and signs, how it's diagnosed, mainly with ultrasound.
And how the initial management focuses on those conservative but crucial steps.
Yeah.
Elevation, exercise, skin care, and especially compression.
Then we moved into the severe end, venous ulcers, understanding they're a direct result of that pressure, the importance of the ABI check before compression.
Right, and the multi-pronged approach to wound care debridement, managing infection, choosing the right dressings, and always maintaining that compression to treat the root cause.
And it really hits home, doesn't it? Knowing the why, the valve failure, the pump dysfunction, the resulting high pressure, makes it so clear why things like compression, elevation, and exercise aren't just nice suggestions. They are fundamental treatments.
Precisely. It's all about consistently fighting that pressure and supporting the return of blood flow.
So thinking about how incredibly common chronic venous disease is, how much suffering venous ulcers cause, and especially those high recurrence rates you mentioned, what does all this information from your sources really imply for the long haul? It seems to point towards a real need for ongoing patient education, commitment to those management strategies, and regular check-ins, doesn't it? This doesn't sound like a one-and-done kind of condition at all.